Welcome back. My name is Dr. Rob McIntosh. I am current head of psychology. I'm also a member of the Human Cognitive Neuroscience Research Group, which is a part of CIVIS. I've been asked to chair this session. This is a session of profit papers. So as you can see from your programs, there is quite a diversity of topics. We're going to try and get through a talk every 10 minutes.
Thanks for the introduction. I just want to take the opportunity to present to you some fairly recent novel work we've done in this area as part of the Edinburgh Preclinical Imaging Group here at Little France. So I'll give you a bit of an overview of what I'm going to talk about. So I'll talk about the scientific rationale behind the project that we embarked on to look at pregnant mice by MRI, and then the MRI techniques that we developed to look at this species. So we had to start off with some structural imaging of the pregnant mice, because detailed, clear structural scans were important to be able to localise on the animals for the further studies. We then went on to look specifically at the fetal brain and applied proton magnetic resonance spectroscopy to the brain. I'll discuss some of the results on that and then some of the challenges we faced on doing this work. We have taken the study a bit further to look at T2 star mapping, generating T2 star values of fetal brains to look at brain inflammation. I won't have time to talk about that. I do have a poster today, so hopefully you can get some information from that or ask myself or anyone of the project team. So the rationale behind what we did was to look at preterm birth. So in humans, between 23 and 32 weeks of pregnancy, the fetal brain is at a critical stage of development and can be vulnerable to injury. 20–50% of infants that are born prematurely in the world have long-term neurodevelopmental problems, and prematurity can also cause up to 1 million deaths a year. So it's quite a significant global healthcare problem. So we wondered if we could do studies in animals, a mouse model of preterm birth, and look at the fetal brains of the mice and apply proton magnetic resonance spectroscopy to them to look at the biochemical and metabolic profile of the fetal brains in utero, and while the embryos are still inside the mother, and obviously it's an alive system. And if there were any differences in a preterm birth group, would this help to explain any of these any of the human findings of human babies that face these neurodevelopmental problems? And obviously being able to translate from mice back to the clinic is always the goal of preclinical studies. So the first thing was structural imaging. So these images were generated in about 4 minutes on our 7T preclinical MRI scanner, and we're really pleased to get such fine structural detail. One thing I should allude to is the sheer scale of this. I've put a scale on there, so that's I guess a 1 centimetre bar. So these embryos are only about the size of your thumbnail. So we're talking about really small structures that we're trying to investigate. So to orientate you around this image, this is a day 16 fetus in the mother, and we can pick out really quite clear anatomical details of the fetus. So we can see the fetal brain, the fetal heart, the liver here, and the spine. And there's obviously mice of multiple pregnancies, so we can pick that up in a few of the fetuses. And we also want to look at the structural detail of the mother while pregnant. So here we've got another fetus, but in addition to that, you can see the placenta in the animal, the liver of the mother, the kidney of the mother, and some leg muscle there. That essentially we used a lot of those reference points for our T2 studies. So to go on with the spectroscopy study, now that we knew we could generate clear structural scans, we had a control group of animals that were scanned at day 16 of pregnancy. They were age-matched controls, and then we had a preterm birth group where the mice were administered with LPS intravaginally on day 15. This is known to resemble a subclinical infection that causes preterm birth, so it encourages preterm birth in the animals And these animals were then scanned 12 to 16 hours later, so both on day 16. So a control group and a preterm birth group. And these were the results. So we localised on the fetal brain, so this voxel for the spectroscopy is equally small. It's 2.8 by 2.8 by 2.8 millimetres, so really, really small region. And this was a representative spectrum we could get. And we were really pleased to get a spectrum that looked like this. We've done some work on adult mice brains before, and this metabolic profile was very convincing. And the NAA here is lower than we would expect, which is correct, because NAA is low at birth and it grows through life. So we've got really good quality spectra from these fetuses. But in order to get, we also wanted some quantitative measure. So we used a fitting program LC model. I guess anybody that does spectroscopy, MRI spectroscopy will be aware of this package. And what it does, it quantifies these brain metabolites, references them to total creatine, which gives a measure of global brain function and remains constant. So we took all the animals that we had obtained spectroscopic data from and ran them through this LC model software to get some quantitative numbers out. And these were essentially the results. So we've got our control group and our preterm group, and we felt we could reliably measure 4 metabolites. And the interesting finding we got from this was the glutamate levels in our preterm birth group were much elevated over our control group. So that was a very interesting finding. When we thought about that, then we think, well, glutamate is an important neurotransmitter, but in a large excess it can be neurotoxic, and that can then affect fetal brain development. So this abnormality we found in the glutamate levels, could this then explain the neurodevelopmental disorders if we were to translate that back to humans that babies exhibit in life? And then obviously would this then have a clinical relevance for bad pregnancy outcomes in the clinic? So that was a good result. We had a couple of challenges along the way with our structural imaging. So you can see here we've got some nice clear detail of the mother's organs, but anything associated with the embryos and the placenta are all very blurred. So it looks like the uterus, these animals are under anaesthesia to keep them stationary during the scans. So that this was a slight problem for us because we can't localise on a brain to do the spectroscopy, and we couldn't obviously generate any T2 star data. So this was an unexpected finding, and it's most evident in our preterm birth group. So they're the most likely to be in labour, and so it was one of the challenges we faced when doing this work. So we tried to image as early as possible after the treatment for the preterm birth group to try and prevent this uterus contractility. Another challenge we had was fetal movement. Again, we anaesthetised the mother, and I guess the assumption was that everything else would be immobilised, all the embryos included, but that is found not to be the case. So we've got an embryo here where we've localised on the brain at the beginning of the scan. We do the spectroscopy scan in the middle, and then 20 minutes later we create an after scan, and you can see the fetus has moved out of the voxel, which is a challenge. You can see it from the 2 placenta here that are at the edge of the animal in the first scan, and something's happened here where the placenta have moved as well. So there's movement during the period, which is a problem. So the anaesthetic doesn't immobilise the fetuses within the animal, which can be an issue. The mother is obviously breathing, so that can cause a bit of movement, and you can get some bladder emptying, which could make things move around. So a slight challenge there as well. So the only way we found to prevent that was the animals presented to the scanner on its front. So we can, and there's a hard plastic sort of casing for the holder. So we felt that if we choose an embryo closest to that, it's maybe fixed in place a bit more. Or we had multiple pregnancies with tightly packed sacs, helped to keep things in place, and we tried to shorten the proton magnetic resonance spectroscopy sequences as much as possible to prevent this happening. So just some conclusions then. Some of the first in utero MRI studies of pregnant mice when they're being applied to the fetal brain. We've developed protocols for successful structural imaging, proton magnetic resonance spectroscopy, and T2 star studies. Hopefully I've shown you some of the initial challenges and made you realise how the proton magnetic resonance spectroscopy results with increased glutamate are really quite promising. Just to finish off, just to acknowledge the BRR staff here. They were the ones that involved in supplying us with pregnant mice, so congratulations to them for that. Funders for letting us do the work, and we've actually just had the work published in the BBA Molecular Basis for Disease journal as part of a bigger study, so we're quite happy that it's reached a nice conclusion. Okay, thank you.
Well, thanks very much for the introduction and for the opportunity to speak about our work on MRSI thermometry here today. So first, a little bit of background. So brain temperature regulation and physiology are not well understood, and that's partly because it's very difficult to measure the temperature of the brain non-invasively. So the brain is not easily accessible to thermometers. However, we do think that brain temperature is an interesting and important thing to measure, not least because therapeutic hypothermia is known to be effective in protecting the brain following cardiac arrest and also neonatal hypoxic ischemic injury, and possibly also following other forms of brain injury. So it's not surprising that there's a lot of academic and commercial interest in developing head cooling devices, particularly here in Edinburgh. But it's difficult to develop these devices and to assess their performance if you don't know what effect they're having on brain temperature. But there's no gold standard method available for doing this. One of the best methods is probably magnetic resonance spectroscopy, and in particular magnetic resonance spectroscopic imaging, which I'm talking about today. So in the background here is a standard high-resolution MR brain image, and in the foreground I've overlaid a coarse grid of MRSI voxels. And in each of these voxels, instead of getting the traditional intensity value, we get a spectrum, and this has signals from water and also from the brain metabolites, so choline, creatine, N-acetyl aspartate. And it turns out that the frequency difference between water and NAA is temperature dependent. So if you can estimate this frequency difference, then you can estimate the temperature as well. And if you do this in every voxel, then you can build a temperature map like this. So in principle, this is very useful. However, it's not a technique that has been widely used, and the reliability thus far is unknown. So that was the reason for starting this study to assess reliability of MRSI thermometry, particularly in healthy volunteers, and also to look at whether going from 1.5T to 3T brings benefits. So we recruited 11 subjects, and they had 4 back-to-back temperature scans. And they had this on 3 different occasions, and they did the whole study in 2 different scanners. So the 1.5T scanner at Brick and the 3 Tesla scanner here at Crick. We recruited a further 20 subjects, and they had just a single temperature scan at 3 Tesla. And everybody was scanned using a single 10 millimeter axial slice located somewhere towards the center of the brain. So at the end of the study, we had about 14,500 valid values for temperature, which we analyzed using a mixed effects model. So first of all, we looked for the variance components, and we found that subject-to-subject variation was about 0.2 degrees. And as you would expect, that was similar regardless of which scanner you were using. The day-to-day variability was also similar at about 0.2 degrees. However, for repeat scanning within the same session, this became more repeatable if you went from 1.5T to 3T. And this is what you would hope for, because when you go to 3T, you have more signal-to-noise ratio, and therefore your frequency estimates should be more precise. However, the largest source of variability was within brain, or voxel-to-voxel variation, and that was at around 0.5 degrees. Finally, we saw a systematic effect, a brain cooling effect. So in these volunteers that had 4 back-to-back scans, as we went from one scan to another, their brains did appear to cool very slightly, and that was true for both scanners. So we looked at the within-brain variation in a bit more detail. We looked at differences between the hemispheres. The differences were very small, but the left side we found was slightly cooler on average than the right hemisphere. We also looked at tissue differences, and we found that voxels containing substantial grey matter appeared to be cooler than voxels that were mostly white matter. So that might be that there's a temperature difference between these two tissue types, but equally it could be that we need to use a different calibration curve depending on which tissue we're looking at. So there's more work to be done there. Now we measured temperature in two other ways. We looked at ear temperature and mouth temperature, and reassuringly, average brain temperature was positively associated with both of these quantities. So if you're looking at quite small temperature variations, it's important to try and quantify any effects that scanner imperfections and drifts in the scanner performance might have. So that's why we designed an MRI temperature-controlled phantom or test object. So this was the design here, and it's spherical. It's divided into two hemispheres, and in each hemisphere you've got a ball which contains brain metabolite solution. So here's the phantom in action in the scanner. Meanwhile, in the control room, you've got these two water baths, and they're pumping hot water down these tubes and through the phantom. And this allows us to control the temperature of the phantom fairly precisely. And we can measure the temperature deep inside the phantom using these fiber optic MRI-compatible thermometers. So the phantom worked well. It scanned nicely. We got good quality spectra. And if you set the two sides to slightly different temperatures, you can instantly see this in the MR temperature maps. So we ran a similar series of experiments to those done in Vivo. We set the temperatures to slightly different values. We performed 5 back-to-back scans, and we did this on 4 occasions, and we repeated it in the same pair of scanners as before. So in terms of the random variability, this was much lower than we found in Vivo. So this is the day-to-day and the repeat scanning variability. So really the repeatability was so high that it's difficult to quantify accurately. The systematic errors were also smaller than we saw in Vivo. So you recall in the healthy volunteers we saw this small brain cooling effect, and we wondered whether this was real or was it just a drift in the scanner. But actually when scanning the phantom we saw minimal drift in the temperature. And similarly, we didn't see a big disparity between the hemispheres. So in conclusion, we've quantified variability associated with MRSI thermometry, and hopefully that will be useful for planning future studies and powering them appropriately. We found that scan-to-scan repeatability is slightly higher at 3T compared with 1.5T. And we've seen that small changes and differences, both temporal and spatial, can be detected using this technique. So hopefully that bodes well for using MRSI thermometry to assess, for example, brain cooling strategies. If you want to read more, the paper's just come out. So finally, I'll just thank everybody involved in this research, and especially the volunteers. The CSO funded the project, and if I can also draw your attention to the ISMRM British Chapter Scientific Meeting, that will take place here in Edinburgh next year. So hopefully lots of people here will be getting to that. Thank you for your attention.
Okay, so thank you for the introduction. So there's been quite a few concerns on the effect of maternal substance abuse and stress to fetal brain development, such as cognitive, psychiatric and psychological disorder, schizophrenia, and so on. So here at Clinical Research Imaging Center, we're looking to study the fetal brain development using MRI in normal stress and pregnancy involving substance exposure. So far, we've recruited and scanned 77 pregnant women, 33 from the control group, 14 from the maternal substance abuse group, and 30 from the maternal stress exposure group. So we run 2 protocols side by side, the first one being the long protocol, where we recruit and scan pregnant women at 24 to 27 weeks. And we get them to return back for a second scan at 35 to 38 weeks. But not all pregnant women return, as you can see here. So as a compromise, we run a short protocol where we only recruit and scan pregnant women at 35 to 38 weeks. So all our scans are done using 3T Siemens MRI scanner, using body and spine matrix coil element, with specific, and all our protocols have a specific absorption rate of less than 2 watts per kilogram. The pregnant women are positioned decubitously on their side to avoid any sort of vena cava compression, as well as patient feeling faint. So the kind of protocol that we run, so of course, MRI is brilliant in the sense that it can produce images of higher contrast compared to ultrasound. So of course, the effect of shadowing from the colorium and low amniotic fluid volume does not affect MRI images as such. However, the biggest challenge for us, for fetal MRI is the fetal motion itself. So the ultimate challenge for physicists as well as image analysis experts is to develop fast scanning sequence or fast and robust method for motion correction for fetal motion. So the kind of protocol that we run, the fast sequence that we run, is Hayes scans to acquire 25 to 50 slices of fetal brain in a period of 4 to 5 minutes. And the resolution of the images is 0.55 by 0.55 by 3 millimeter cube, as you can see there. And all our scans are run without the mother holding the breath. We run 3 Hayes scans in each direction, so axial, sagittal, and coronal. And so a minimum of 3 times, so we end up having a minimum of 9 image series, which we then use to do motion correction using slice MRI motion estimation and reconstruction, which we'll call slimmer. By doing this motion correction, we then form a 3D high-resolution brain image of 1 by 1 by 1 millimeter cube. So, so far we've done 45 fetal brain motion correction for 24 to 27 weeks, and 60 fetal brain acquired at 35 to 38 weeks. Like I mentioned again, the fetal motion is really, really excessive in certain gestation, especially at second trimester. So the 3D reconstruction of fetal brain was not possible in 11 fetuses from this gestation. So this is just an example of what we acquire. As you can see here is the fetal MRI images of the fetal brain. 25 week at the top and the 36 week at the bottom. And I've just kind of put up an illustration of neonatal brain just to kind of complement what's happening in the maternal womb. And what I'd like to highlight is at 25 weeks, there's so much space in there that the fetal can actually party if you wish. 36 week, there's not much of motion, but there is still a bit. It's more of a rotation and a tiny bit of translation because the fetus is quite nicely engaged in the maternal womb, waiting to be delivered. So using slimmer, this is what happens for the original image. 9 series of image would go into slimmer at known distance apart. But obviously, if you do the imaging with fetal motion, the tissue are either going to be oversampled or undersampled. So when we use slimmer to do motion correction, the tissues are then rematched, aligned back to back. And once this motion correction is done, this is the kind of images that you get. The slices are no longer at known distance apart. And using algorithm in slimmer, it then produces a 3D fetal brain, which would look like this. So that's the original image, and after motion correction, this is the kind of image you'd get at 25 week and 36 week. So it shows good detailed image of a gray matter and white matter, but not all our images look as beautiful as this. So we rate our image quality after the 3D motion correction. So A being very good, B being good, C moderate, D poor, and E failure to do any self-motion correction. So you can't do any motion correction, and once you build up the 3D image, you can't take it further to do segmentation. So this is our data analysis chart. At 24 to 27 week, there's a success rate of 45%, and 25% of the data, which is representing 11 fetuses, were not used for motion correction at all because there's so much excessive motion. It was failure to do motion correction there. But if you look at 35 to 38 weeks, this 83% of success rate, which this fetal data, 3D fetal brain can then be used for further segmentation. And the good thing is we did not have any issues of not being able to do any 3D motion correction for 35 to 38 weeks. So the resulting 3D dataset is then input to analyze 10, where we use isotropic capillary asterology method. We used to estimate brain volume as well as the surface area of the fetal brain. So we looked at whole fetal brain, cerebrum and cerebellum. And I'm just going to show you an example of what isotropic means. Basically, when you get a 3D brain image, you're getting 150 slices out of the 25 to 50 slices of images you take. After the motion correction, it now has 150 to 200 slices. So you randomly rotate this 3D brain, pick out a plane somewhere in the middle, and you generate a known number of slices, let's say 10, at known distance apart. So example would look something like this. And you sphere points on this image, and the region of interest, the points in the region of interest, as you can see here in green, very light, sorry, would then be picked. And these total points are then going to be used to compute the total fetal volume. And for the surface area, there's a grid, which is very light, again, at known distance apart. So all these grids, basically when it intercepts with the region of interest, it's point counted, and the total points are then going to be used for volume, surface area measurement using these formulas here. So far we've only looked at the fetal brain volume and surface area measurement at 35 to 38 weeks in the substance abuse group as well as the control group. We haven't looked at the stress group yet. So by correcting the data statistically for birth weight and gestational age, you realize intracranial volume and cerebral volumes were significantly lower in the substance abuse group, ignoring the gender effect. But if you look at gender, the exposure is more effective on the male group for the intracranial, and the cerebellum, the female were more exposed. So surface area, there's not any significant difference for both either non-exposed or substance abuse group. But if you looked at gender, there was some sort of effect for the PL surface area for the substance abuse female. So for discussion, of course, fetal brain motion correction is not possible. However, the quality of the fetal brain motion correction is very dependent on the degree of fetal motion as well as the bias fill in homogeneity during the scan. The fetal movement, as I mentioned, is more excessive during the second trimester compared to the third trimester, so it's more challenging to correct for. Of course, nonetheless, we did our study, and looking at our results, fetal, intracranial, and cerebellum volume were reduced by maternal substance abuse. So our plan for next future work is to analyze all the fetal brain volume as well as surface area at second trimester and third trimester in all the 3 cohorts to look at the difference in the growth in the exposed fetuses across gestation. Of course, we'd also like to look at the reliability of fetal brain measurement using isotropic capillary by comparing them with semi-automated segmentation technique such as edge detection, thresholding, or inversion in contrast, or even doing manual segmentation to start. So that brings me to my thank you slide. Thank you.
Okay, thank you very much for the introduction. A slightly different tact with this presentation. I'd like to give you an overview of our vampire project, where we accidentally created a brand which has stood us in good stead. To give you a bit of history about this, it's a project that started around about 2007, which brought together some independent research that was happening across the universities of Edinburgh and Dundee into retinal image analysis. And we figured that we could achieve much more working together than working apart or in competition. And it's allowed us to create what we now have as a core team of 2 coordinators, myself and Professor Manuel Trucco. We have a research associate and 5 PhD students, plus various collaborating clinicians from the 2 universities and also the NHS health boards of Lothian and Tayside, as well as various final year students working on projects with us. And really the aims of the Vampire project have been to establish a world-class Scottish group centre for retinal image analysis research, integrating not just the computational but the clinical research as well. And the second aim was to create some software that would enable studies involving retinal imaging biomarkers by allowing efficient and accurate measurements of the retinal vasculature. So why study the retina? Well, hopefully what this diagram illustrates is two things, is that it's quite easy to image the back of the eye, the retina. The pupil provides the entrance and exit for the imaging light rays. And when you image the retina, what you can see is the microcirculation. You can see the blood vessels of the retina. And why that's useful is these blood vessels are excellent markers, not just for the circulation of the rest of the human body, but also because of where the eye is located, which is in such close proximity to the brain, that the blood vessels of the eye are excellent markers for what's happening within the brain and also the central nervous system. And this opens up a whole range of possible areas of investigation, where we have a range of diseases that are either linked to or affect the circulation of the human body or are linked to the human brain, things like diabetes, cardiovascular disease, stroke, dementia, a whole range of disease areas. And also, it's possible with another optical imaging technique to interrogate just below the surface of the retina and look at the retinal nerve fiber layer, where there are manifestations of neurodegenerative disorders, such as MS being the one that's hit the news in the last couple of years. So the eye is this really accessible and exciting and interesting and versatile research site for imaging and research and a multitude of diseases and disorders. So the three sort of main technologies for imaging the retina are fundus camera, scanning laser ophthalmoscope, and optical coherence tomography. This is the sort of most common, is the images you get from a fundus camera give you these orange pictures, and you can see the blood vessels at the back of the eye quite clearly. The scanning laser ophthalmoscope, as the name implies, uses a scanning laser to build up a much larger picture of the back of the eye in one go. So the circle here shows what the fundus camera would do, and clearly the SLO device is able to image much more of the back of the eye in one go. And then the third imaging technique, optical coherence tomography, can interrogate just into the surface of the back of the eye, where we can look at the different fiber layers that make up that tissue. So that leads us on to what we could use these pictures for and how that would be useful. And it really comes down to the fact that the vascular network in the eye is set up, it's optimized for flow, to make flow more efficient or most efficient. And what we're looking for is within these various diseases, is that within the disease process, we're seeing deviations away from this optimum pattern. We're seeing differences in the arrangement of the vessels, differences in how they bifurcate, differences in vessel width, if they're narrowing, if the network is changing in its complexity. And these differences are quite subtle. Hence the need for software to measure some of these parameters in objective and efficient ways. And a lot of these differences would be missed by a human observer just visually inspecting an image. So we have our software, which is set up to allow people to load in retinal images. We've been through lots of image processing development to automatically segment the blood vessels at the back of the eye, and then algorithms to perform different measurements, such as measuring vessel width, looking at properties like tortuosity, looking at the geometry of bifurcation, and then things like fractal analysis to identify changes to the complexity of the overall network that you see. So to give you an example of how we're actually using the software and the imaging in clinical research, we have a project on the go at the moment in the Clinical Research Imaging Centre, where one of our PhD students, Gavin, is imaging people who are coming into the centre who are taking part in a trial called ScotHeart, looking at how CT technology can benefit the diagnosis of coronary heart disease. And piggybacking onto that, we're capturing retinal images from these patients and quantifying the vascular features using our Vampire software. We then want to compare the vascular features to CT diagnosis and also retinal data from healthy volunteers and see if we can establish whether we can spot signs of coronary heart disease in the eye. And the question at the bottom there is there a role for retinal imaging in patient stratification? Not everybody might need to go for a CT scan. There are some people who have chest pain but have no diagnosis of coronary heart disease on the CT scan. They don't necessarily need to go for a CT. So could we spot those people with retinal imaging by, say, putting a retinal imaging device in the hospital in the chest pain clinic? And maybe even further, a step removed from that, could retinal imaging go into primary care, into an optician's practice, and could opticians actually start looking for signs of coronary heart disease? And it's a question that we've not answered yet. We're about a year away from the end of that project, so hopefully this time next year we'll be able to deliver some results on that. In terms of Vampire used in clinical research, we've used it in stroke in collaboration with Professor Wardlaw, using the retinal vessels as a surrogate marker for small vessels in the brain. We've looked at age-related cognitive decline, and we're processing some data in collaboration with Ian Deary's LBC group. We have projects on the go looking at cerebral malaria. We're looking at malnutrition in children, coronary heart disease, also cardiovascular disease through the Orcades database with Jim Wilson. And we've also been the first team to look at retinal images in the UK Biobank, again in relation to cardiovascular disease. And I estimated that we're up to the point of having analysed greater than 10,000 images in total with our software. In the future, we're really interested in looking at neurodegeneration with colleagues from the recently opened Rolling Clinic and trying to use the imaging technology of fundus imaging in conjunction with OCT. I'll just move on to this next slide, which is our most stable release of the software, will be arriving next year. So we're really interested to hear from people who have retinal images or are interested in using retinal images in clinical research. So I would point people to our website for details about publications featuring our software. My contact details are there, and various people to thank in the development of the project in the software and helping us with our clinical research. So thank you.
Thank you for your introduction. I'm going to introduce you a new registration and segmentation framework for adaptive radiotherapy based on image processing tactics. Firstly, I believe we are all familiar with radiotherapy or radiation therapy, which is curative in treating cancers with localized tumor volume. And medical images like structural, functional, or histological images are commonly used to guide the process of radiotherapy. Therefore, automatic segmentation of the gross tumor volume on the follow-up medical images is very important for adaptive radiotherapy planning between different fractions or between different time points within one fraction. However, accurate identification of the gross tumor volume is very difficult because, firstly, uncertainties of the soft tissue position and internal organ motion. Secondly, the response of the gross tumor volume to radiation is difficult to predict, which may cause anatomy changes. Thirdly, it's very difficult to combine the information from multimodality images because of the distortions and the contrast variability between them. Here in our project, we aim to find an automatic segmentation approach of the GTV on the follow-up medical images by combining the information from multimodality images. Here is the flow chart of the framework. Basically, we have two data sets, a pre-treatment reference image and a post-treatment target image. What we want to do is we want to use the information from the pre-treatment image and get the segmentation result automatically on the post-treatment image. So we apply a rigid registration firstly to find the best rotation and the translation parameter between them. This is actually enough for the images with the same modality, like between CT and CT. But if the images with different modalities, like between CT and MR, between CT and ultrasound, we need a non-rigid registration algorithm to deal with the distortions. So after the registration, we will get a target image with the registered pre-treatment contour. This contour will be used as the initialization of a level set-based segmentation algorithm, which is very robust and can track the shape change of the gross tumor volume on the target image. The algorithms in this framework include a rigid registration algorithm. It's based on scale invariant feature transform and mutual information, and it's proved to be generally suitable between any different modality I will introduce you the result later. The non-registration algorithm is also included in this framework. It's a cubic B-spline-based algorithm, and we give it a novel similarity function. The segmentation algorithm is a gradient-based level set method under appropriate parameter setting and initialized with the registered GTV contour. I also gave it margin is 3 to 5 pixels. And here are an example of the registration results. On the left, you can see is, two original images. On the top is a reference image. It's a pre-treatment CT from a Canadian patient. The target image is a CT image after 6 weeks treatment. And we apply the rigid registration firstly here in the middle. It includes rotation and translation. And after we find the best parameter, we use a B-spline-based algorithm here as a B-spline control grid to refine the result. And then we get the final registration result here. The red contour is actually registered from the pre-treatment CT, and the blue contour is the clinical contour on the CT 6 weeks. We want to next is to use the red contour, the information of the red contour, and automatically find the blue contour. But before that, we want to assess the performance of the registration. Here are the results of different similarity measurement for different rotation parameter between MR and the CT image. On the top left is the sum of square distance of the whole image. The second one is the sum of square distance between the feature points. Third one is the mutual information between target and reference image. The last one is what we are using in the framework. It's a mutual information between the saved feature points. You can see clearly the first two give us acceptable result, but it has several local minimums around the global one, so it makes us difficult to find the actual minimum. And the third one gives us results with huge error. You can't just ignore it. The last one gives us a single and clear global minimum, which can be found very easily. And this is a similar performance around the translation field. The first one here, sum of square distance, actually give us acceptable result, but the value is quite similar, so it makes the optimizer less efficient. And the second and third one has huge edge effect. You can see there are minimums around the corner and edge in the parameter space. But the last one, the visual information between feature points we are using in the framework, again give us impressive result here. So this proves our registration algorithm is suitable between multimodality and can give us efficient result. Here are some segmentation results, as you can see. On the left is the reference image. It's a pre-treatment CT from patient 2, and in the middle is the target image is CT 12 weeks after treatment. What we want to do is to use the blue contour here and find the target contour, the yellow contour here. If you can see it clearly here, the red contour is generated by the framework, and you can say it's quite similar to the target yellow one. And we actually use DAS coefficient to assess the performance. The DAS in this case is around 88%. And we also test the framework between different modalities. In this case, the reference image is the pre-treatment MR, and the target image is a CT 12 weeks after treatment. And after the framework, we found the red contour here. The DAS coefficient in this case is even better. It's nearly 90%. And we can also improve the result by parameter setting. Those two images are actually the same image. And difference is on the left, we set the parameter to find better overlap. But the level set method will ignore the details like this middle circle within the contour. But on the right, we set the parameter to find the contour with more details. So it's accurately find this little circle inside, but give some noise. So this proof of framework have the potential ability to give us different results and based on different preferences. Here is the overall performance over the 4 candidate patients we have tested. All of them are above 70%, and the overall performance is 84.44%. That's all. Thank you for your attention.
Yes, the last talk in this session is Dr. David Carmel, but David can't be here today, so he's asked me to give his talk for him, which is a little bit strange. I will do my best. David's given me far more slides than I would attempt to get into 10 minutes, so we'll see how that goes. And the primary purpose of the talk, really, is to keep colleagues in the imaging community aware of the research facilities in brain imaging and research technologies that are allied to brain imaging that we have at Central Campus in psychology. So the only true brain imaging technology here, we have 2 biosemi labs for EEG recording brain activity from the scalp surface. We can combine that with eye tracking, which is a great behavioral measure of ongoing cognitive activity. My own lab, which is a motion tracking lab, we can combine that with EEG, and we can combine it also with TMS. So here we study not just eye movement behavior, but also how eye movements are coordinated with hand movements and other body movements. And the technology that we're going to talk about today, so the newest lab established, there's a dual lab for TMS, transcranial magnetic stimulation, and TDCS, which is direct current stimulation of the brain through the scalp. And what you see here is David Carmel pretending to stimulate one of my PhD students with a TMS coil. If you've missed our poster, it's probably too late to see it now, but come and visit our websites. And if you're interested in using any of these facilities, then David is the man to contact, as he's the current director of these facilities. So this is the TMS setup. What you have here is basically a big capacitor that discharges an electrical current around these coils very rapidly, and that induces a magnetic field in an orthogonal direction, which passes through the skin and the scalp into the brain tissue, where that then induces an electrical current within the brain tissue, and that causes a disruption, a very temporary, localized disruption of brain activity in the targeted brain area. What you'll notice here as well, we've got these kind of antennae with these rather shiny balls on the top. These are infrared antennae, and we have a bank of 3 infrared cameras that spatially localize the positions of these. So you can localize the participant's head, you can localize where the coil is, and if you co-register the participant's head position with their MRI information, which you've collected beforehand, then you can precisely target a particular area of their brain. And what you're trying to target is essentially this magnetic field that's being induced here, which is inducing a current in the targeted brain region. We use figure-8 coils or butterfly coils, and that's particularly useful because the 2 fields interact, and that will produce a nice localized peak of activity. So you can be relatively, of course, the activation spreads rapidly, but the initial site of disruption, neurodisruption, can be quite precisely targeted down to about 1 centimeter or so. So the first respect in which this is allied with MRI is that we use MRI to guide the targeting of the TMS pulse to try and disrupt a specific brain region or regions of voxels within the MRI. So in the best case scenario, you've pre-scanned your participants in the MRI, and you co-register some salient points on the scan and on the participant's head, and then you can get an ongoing display using our BrainSight software of where a model of the TMS pulse, giving you a picture of exactly where it is you're stimulating. So you can stimulate a precise position in the brain using this technology. Okay, so if you can do that, what do you then do with your TMS? Well, you can do various different protocols with the TMS. Perhaps the simplest one is online, where you just get a participant performing a behavioral task, and you give them a single pulse. So you just disrupt brain activity in a certain area of the brain just for a few milliseconds during an ongoing task. and you see what impact that has upon performance. The studies that I'm going to mention today are done using a different method, offline, where you use repetitive TMS. So here you're giving a TMS pulse at a rate of about once every 5 seconds up to about once a second, so low-frequency TMS pulses over an extended period of time. At this low frequency, you tend to get a depression of brain activity in the time following that, and a rough rule of thumb is that you get about that depression of activity for about as long as you stimulate it. So if you stimulate someone with this repetitive protocol for 15 minutes, that gives you about 15 minutes afterwards to get them in the behavioral task that you're interested in. Higher frequencies seem to cause increased activation of the targeted brain region in the period following the repetitive stimulation. And there are other protocols available as well. Should mention as well that the actual strength of the signal you give can be thresholded, and normally you would try and evoke movements or evoked muscle potentials in the hand by stimulating motor cortex, and you can use that as a rough measure of the participant's sensitivity to the magnetic stimulation, and you can use that to threshold. So normally you'd use something like 70% of the motor threshold would be the strength of TMS that you'd use in your experiment. The next question people tend to ask after what is it is it safe? That sounds horrible. You're going to start zapping my brain. The short answer is yes, as far as we know it's safe. The long answer is this. There's the transcranial magnetic stimulation TMS consensus group. They meet annually to look at the risks and derive the best safety protocols that they can. As far as we know, as long as you follow these safety protocols, there are negligible risks. There's been something like 9 epileptic seizures ever recorded in the use of TMS. So exclusion criteria would include people with epilepsy. Obviously, anyone with any metal implanted in their head is also not a good participant. Why would you use it? Well, it's a complement to other existing methods we have of studying the relationship between brain activity and cognition and behavior. So, of course, if we want to study associations between brain activity and behavior, we have single unit recording in awake-behaving animals, and we have functional imaging of human brain activity, awake subjects doing various tasks. But these are all correlational methods, so you can't infer causality from this. Just because a brain region is active during a task doesn't tell you anything about what role it's playing in that task, nor even whether it's actually playing any necessary role in that task. For that, you need to actually run an experiment where you manipulate the brain activity and observe the effect on the task, and that allows you to make stronger causal inferences. And this is where interference techniques, of course, come in to allow you to make causal statements. And again, we can use animals, we can use animal lesions to make lesions in the area of the brain we're interested in. In humans, the ethics won't permit us to make the lesions in the area we're interested in, so we have to wait for accidents of nature, often stroke, something like that, to cause localized lesions. And we can do these patient studies to find out what sort of behavioral and cognitive problems patients experience after having a lesion in a certain area of the brain. It's a powerful technique, but there are a lot of problems with it. One problem is that if a patient has a brain lesion ongoing, the brain can reorganize. So or the functions can reorganize. So the behavior that you're observing is not necessarily just the brain minus that bit that was previously doing a job, but maybe, if you like, a whole brain response or reorganization in response to that brain injury. Obviously, it's irreversible. If you want to do precisely targeted lesions, then you're working with monkeys and animals, and we've already heard monkeys and lower vertebrates, and we've already heard that that may not be a great model for humans. Doesn't give you any information about how different cortical areas might interact with one another during behavior or a complex cognitive task, and it doesn't give you any information about when those areas are important during the time course of a task. TMS, if you like, has a lot of complementary strengths here. It's over so rapidly there isn't time for functional reorganization. It's fully reversible, at least according to the safety guidelines. We can study healthy humans with this. You can, if you use two TMS coils stimulate different areas of the brain at different points within a behavioral sequence. So you can study cortico-cortical interactions during a task, and it's temporarily very precise. So at least the online single pulse TMS during a task will disrupt brain activity just for a few milliseconds during that task. So you not only have to hit the right spot in the brain, you have to hit the right point in time to disrupt performance. And that can tell you a lot about which brain areas are involved in a task at what point in the sequence. Okay, so the study that I'm going to just very briefly describe, just to illustrate the use of TMS, is in David's research area. David's particularly interested in perceptual awareness, and in this case, in interfering with perceptual awareness and manipulating it using TMS. The reason for choosing this is that this is a nice example of two ways in which the use of TMS is naturally compatible or complementary to imaging techniques, structural and functional. So the phenomenon that's being used here is bistable perception, binocular rivalry. And the basic idea here is you present one image to one eye and another image to another eye. And you can do that using these red-green spectacles here, so you can filter the images so that the left eye, for instance, is looking at a picture of a face, while the right eye is looking at a picture of a house. And these images are sufficiently dissimilar that most of the time what we don't see is some kind of combined version of these two images on top of one another. Normally the brain will choose one or other version to present to conscious awareness. So we're normally only aware at any point in time of seeing a face or a house, and that perception will flip over time. So people will have dominance of the face at some point, meaning that they're suppressing the image from the other eye, and then that might flip and the house might become dominant for another time period. And this will go back and forth like any other ambiguous figure, with periods of stability and periods of change. Psychologists interested in awareness like phenomena like binocular rivalry very much, because you have a nice experimental situation where the physical stimulation doesn't change. You're presenting exactly the same stimuli all of the time, but the phenomenology changes. So what the participant is experiencing changes, and you can get them to report on their experience so they can press a button, for instance, to indicate whenever the percept flips. And if you get people to do that, you can get them to do it in a brain scanner. So you can put them in an MRI machine, show them rivalrous stimuli, one image to one eye, one to another, and you can ask them to report using a button push when their perception flips so that you get a change in the eye dominance. This is a very influential study that did that, and you get a number of areas of activation associated with the change in the dominance. You get visual cortex, obviously. This is a visual task. But you also get quite strong activation in frontoparietal network that we know is involved in the control of attention. And in particular, you get a high peak of activity in the superior parietal lobe, the anterior portion of the superior parietal lobe, which seems to be particularly active during periods where people report, or rather immediately after periods, where people report that their perception of the stimulus has changed, that the dominance has shifted. So this is a kind of classic recipe for a TMS experiment. What you might start with is an MRI scan in some particular behavioral task that you're interested in, and you find some voxels that seem to be particularly excited during a critical part of that task. And naturally you start to think, well, I wonder what those voxels are doing. I wonder what would happen if I zapped them and got people to do this same task. And so this was the rather simplistic logic underlying this experiment here. David and colleagues, basically they zapped in a number of healthy volunteers the region that was preferentially activated during these flips of perceptual awareness, in order to see whether it has a causal role in changing perceptual awareness. So they used a repetitive TMS protocol, so they depressed activity here, and what they found is that these participants with depressed activity in this critical superior parietal region had a reduced period of dominance. So their perceptions would alternate back and forth more rapidly than participants than they would under the sham condition, or on participants who hadn't had TMS, or indeed, and it was specific to the right hemisphere. So you didn't get this effect in the left hemisphere, and that was consistent with the earlier brain imaging. So it seems to be that the right parietal TMS shortened the dominance durations, which indicates that it has a causal role, presumably, in maintaining the percept, in maintaining the stability of an ongoing percept. A second experiment they went on to do, which I'll describe, was inspired in a different way. I mean, out of time. Okay, right. Was inspired. I'll rush through. That's fine. Okay, so they noticed some structural correlations between normalized grey matter volume. Basically, if you have a lot of grey matter here, then your percept duration tends to be longer than in people who have less grey matter there. In another part of the superior parietal lobe, more posterior, you have a reverse structural correlation. And that structural correlation with behavior led them to stimulate this more posterior region, and they found an opposite effect. Basically, if you depress activity in this region during TMS, then you get longer periods of perceptual stability with fewer perceptual reversals. So there's an interesting story there to be told between more posterior areas of superior parietal lobe involved in bottom-up changing of the percept, whereas more anterior areas are involved in top-down attention, maintaining your current hypothesis of what you're looking at. Those are the sort of theoretical conclusions for people interested in awareness. The relevant conclusions today are that TMS is useful in determining specific causal roles of cortical regions, spatially and temporally precise, and it's a natural ally of, if you're interested in cognition, of functional brain imaging and structural brain imaging, because it's guided not only spatially for targeting the pulse by structural brain imaging, but you can also be theoretically guided by functional and structural brain imaging in deciding which areas are interesting to zap. Okay, thanks very much.